So good morning, everybody. Thanks for coming to the September Survivorship Lecture Series, it being Pediatric Cancer Survivorship Awareness Month, right? Childhood cancers. We have today Jessica Itner, FNP, speaking. She received her Bachelor's of Science in Nursing at Rockhurst University, then a Master's of Science in Nursing at UIC, where she became a family nurse practitioner. Between this, she has 13 years of nursing experience with pediatric and adult cancer survivors and oncology patients undergoing therapy. So she has a strong background in research and patient education and has done grant work and given presentations on cancer survivorship. She's worked in development of both the University of Illinois Childhood Cancer Survivorship Program and the University of Illinois Rush University and Stroger Hospital Children's Oncology Group Research Program. So I'm very pleased that Jessica has agreed to speak on this topic of pediatric cancer survivorship today. And Jessica, whenever you're ready, I have allowed screen sharing for you.
Great. Thank you, Dr. Mance. Appreciate the warm welcome. Let me share my screen. All right. Let me start the presentation. All right, so thank you so much, Dr. Mance, for inviting me to speak today about childhood cancer, our survivorship program here at UI Health, and childhood cancer survivors, giving a little bit more information about that during, as you said, September is Childhood Cancer Awareness Month. So first, just a few facts about childhood cancer. 1 in 285 children will be diagnosed with cancer by the time they are 20 years old. It is the leading cause of death by disease in children under 19. Around 12,000 children in the United States are diagnosed with a malignancy every year. So that's a large number of children, unfortunately. And despite all of this, only 4% of funding from the NCI goes towards childhood cancer research. So the gap is made up by many different charitable organizations. I'm sure you've heard of some of them. Alex's Lemonade Stand is one of them, where this graphic comes from. So an overview of the different types of childhood cancers. As you can see in this chart, the largest percentage of childhood cancers are leukemias, mostly ALL and AML. The next largest chunk of cancers in children are cancers of the central nervous system. And then lymphoma, soft tissue sarcomas, are neuroblastomas and Wilms tumors, and so on. I always like to point out to our students who are learning with us in our survivor clinic, we have a very large population at UI Health of retinoblastoma survivors due to us having, wonderful retina specialists at the ear and eye infirmary. You would think that retinoblastoma makes up maybe a third of childhood cancers from our patient population, but throughout the country it is 2%. This graph shows the incidence of childhood cancers by age. As you can see, unfortunately, the incidence in all age groups is going up. The bar graphs to the left represent diagnoses from 1995 to 2007. The bar graph to the right, 2008 to 2017. This picture is a little bit older, but I thought it does a very good job of showing survival rates, starting to the left in the 1940s and to the right ending with diagnoses in 2000. So you can see 1940s, 1950s, not so great. 1950s is when we really started using chemotherapy to treat childhood cancer. Before that, we didn't use much chemotherapy at all to treat it. The red line is our most common diagnosis, acute lymphoblastic leukemia. You can see how until 1950, no one survived this diagnosis. And again, it's the most common childhood cancer diagnosis. And so when we started using chemotherapy, and because of the role that clinical trials have played in childhood cancer, luckily now that survival rate is over 80%. So we talked about childhood cancer, under the age of 15. An area that people are focusing more on now, which is a great thing, are adolescent and young adult cancers. You may remember I said 12,000 childhood cancer diagnoses a year, and in AYAs, it's 70,000 diagnoses per year. So this picture kind of shows the interface of pediatric and adult oncology. To the left, you have the endocrine cancers, the pediatric leukemias, lymphomas. In the middle is kind of where both areas of oncology intersect. So both sides see a lot of sarcomas, Hodgkin's lymphoma, germ cell tumors. The adult side more sees the melanomas and thyroid cancers. And then to the very right, you see what we call the adult cancers, the carcinomas. So lung, breast, GI, urinary tract, head and neck. How do we treat childhood and AYA cancers? I like this picture as it shows everything kind of intersecting. Our largest weapon against cancer is chemotherapy. So we use a lot of chemotherapy in pediatric oncology and surgery. The yellow circle represents biologic agents. I think this circle will get larger with time. We have our newer biologics, CAR T cell, and also monoclonal antibodies, things like that. This radiotherapy circle is getting smaller. We really try to use as little radiation therapy as possible in pediatrics, which I'll go into later. So I think this circle with time will get much smaller and the yellow circle will get much larger. So who treats children with cancer? So 90% of children with cancer are treated at a center that is a member of Children's Oncology Group. Children's Oncology Group is the NCI-sponsored Pediatric Cancer Clinical Trials Group. There are over 200 institutions in this group, mostly in the United States, but also a few other countries. There are institutions there. Oh, my apologies. I just went forward to, let me go to the previous slide here. So after childhood cancer, we now have over an 80% 5-year survival rate. It's not high enough. We want it to be 100%, but unfortunately we're not there yet. We're still doing COG clinical trials to hopefully increase that number. There's estimated a few years ago, this is a little bit old, that there are over 480,000 childhood cancer survivors in the United States. So this is a large population of people. Unfortunately, we know that many of these patients end up with chronic health conditions, most times multiple chronic health conditions and significant chronic health conditions. There are 2 large studies that have looked at this cohort to come up with these numbers and this data. I'll talk about those 2 studies in a little bit, but I have data below from one of the studies, the St. Jude Lifetime Cohort. By age 50, virtually all survivors have at least one chronic health condition. And we know that most survivors have at least one severe, life-threatening, or fatal chronic health condition. I'll talk about grades a little bit later, but just wanted to put that out there. Severe is considered a grade 3, life-threatening a grade 4, and a fatal grade 5. So the first study, large study about childhood cancer survivors is the Childhood Cancer Survivor Study. This is a retrospective cohort, a multi-institution that enrolled almost 40,000 childhood cancer survivors. They had to be less than 18 years old at diagnosis in the 1970s to 1990s, and the study used siblings as the controls. So this study did phone surveys about chronic health conditions, had a few major reports, a lot of publications, and from this study, the first version of the Children's Oncology Group long-term follow-up guidelines were created, which I'll talk about a little bit later. So this just shows the 31 institutions that are part of this cohort. The darker blue or black circles are the original cohort, and then they expanded, I believe in the 2010 sometime, I don't recall the exact year, and those institutions are in lighter blue. So this is one of the reports that came out of this study that detailed the risk of severe, disabling, life-threatening, or fatal chronic health conditions in this cohort. And again, the controls were siblings. So you can see in the top right corner, the graph labeled A. You can see the blue line are the incidence of these significant chronic health conditions in survivors. The x-axis is age, so starting pretty young and then going up to age 50. You can see, obviously the blue line is a much steeper slope than the yellow. So as we talk about in our clinic, we compare this or call it rapid aging, basically. The graphs on the bottom, D, are the survivors. They took survivors who at age mid-20s did not have any chronic health conditions and showed the incidence over time to age 50. The second line is starting in the mid-30s, same thing. And then the third line is starting patients with no chronic health conditions that they identified themselves in their mid-40s and how the incidence grew with time. E is the comparison with the siblings, and you can see that. So the second major study with childhood cancer survivors came out of St. Jude. So they call it St. Jude Life. It's a lifetime cohort study. So also a retrospective cohort had to be less than 18 years old at diagnosis. They had to be treated at St. Jude in Memphis from the 1960s up to 2004. They had to be at least 10 years out from their diagnosis, and they had to be at least 18 years of age. So this study was a little bit different in that it was a prospective follow-up with at least one comprehensive medical visit at St. Jude. And when I say comprehensive, it was comprehensive. They followed the Children's Oncology Group long-term follow-up guidelines and did all of the things recommended for those patients, and then also did additional testing at St. Jude. So they were able to evaluate a little over 3,000 patients in person and compared them to community controls matched for age and sex. This is a very busy picture, but I like to include it. I think it does a good job of showing the cumulative burden that survivors have with chronic health conditions. So they split out survivors based on their diagnosis. There's in the top right hand, it gives the different types or the different categories of late effects. And so for each diagnosis, there are 3 bars. The bar to the left are patients at age 30. At the middle bar is age 40, and the bar to the right is age 50. And so the group furthest to the left were the controls. Again, people that had not had a cancer diagnosis. And then you can see the different cancer diagnoses to the right. So to the right of the controls is ALL, acute lymphoblastic leukemia, which again is our most common diagnosis, and then AML, Hodgkin's lymphoma, non-Hodgkin's lymphoma. And then the two most significant, I think, which goes along with what we've seen in our clinic here at UI Health. CNS, our brain tumor survivors really have a lot of chronic health conditions. And then to the right of that, the bone tumors. So what contributes to these late effects? There are three main areas. You can have late effects because of the disease. If you have retinoblastoma and have to have your eye taken out by enucleation, that obviously contributes to late effects. Also Wilms tumor, most of these patients will have a kidney removed. So that's due to their disease. Also, something that contributes are genetic factors. Unfortunately, many of our retinoblastoma patients have a mutation in their RB1 gene, which puts them at much higher risk for secondary malignancies. We have some patients with P53 mutations, patients with Down syndrome. People with Down syndrome are more susceptible to developing leukemia. Fortunately, their survival rates are much higher than patients without Down syndrome, but they are much more sensitive to chemotherapy. So now we know that, and we reduce the amount of chemotherapy that we give patients with Down syndrome. But in the past, they were given the same therapy and had many more toxicities. And the main category that we talk about are treatment-related factors. So what type of surgery you had, what type of chemotherapy drugs, and the doses, radiation, field and dose, and stem cell transplant. We're still learning about late effects from biologics just because some of them are newer and we don't have data 20 or 30 years out. So this is just a list of some of the more common types of chemotherapy agents that we use and associated late effects. So our first category are alkylating agents. Unfortunately, the main one that we follow after alkylating agents are effects on fertility, more in men than women. Also, it can cause cardiac toxicities, pulmonary toxicities, and renal dysfunction. The second category are anthracyclines. We use a lot of anthracyclines in sarcoma treatment, a lower dose in leukemias, usually unless they relapse. But the main one after anthracyclines are cardiomyopathy, left ventricular dysfunction, and it can cause secondary cancers. Steroids are very hard on the bones. We see a lot of osteoporosis, low bone density, and with dexamethasone, we see a lot of avascular necrosis, unfortunately. And then the anti-metabolites are hard on the kidneys, the liver, the bones. Methotrexate, we use a lot of it as it's very good at crossing the blood-brain barrier. But unfortunately, that also means that it causes a lot of neurocognitive late effects, especially in our young children, especially in our ALL survivors that have methotrexate injected intrathecally. And then etoposide, unfortunately, can go on to cause secondary cancers as well. Radiation, as I said before, we are really trying to use as little radiation as possible in our pediatric patients. The younger your patient is, the more radiation-related late effects that you can have. Big one is secondary malignancies, especially as you get 20 to 30 years out of radiation. Also in young children, it alters the development of the tissue. It's hypoplastic, a lot of fibrosis in the radiated area. It can affect growth, especially if given to the brain, can cause endocrine disorders, neurocognitive deficits, and if given to the chest area, like our Hodgkin's survivors have a lot of cardiovascular and pulmonary late effects, unfortunately. So I like this picture or figure as it shows kind of the spectrum of late effects and what our patients go through. You know, we've talked a lot so far about organ function or dysfunction, and also you know, some secondary cancers, but also just, you know, we're taking these kids out of school, away from their peer groups. So it has a lot of effects with emotional and social maturation. The neurocognitive late effects affects their education, their schooling, down the road, what type of employment they can have, what type of health insurance they're eligible for. So, you know, these psychosocial late effects are very, very significant as well. Luckily, we have a wonderful social worker in our clinic, Zaida, who unfortunately can't be here today as she's on vacation, but we'll talk about her role in a little bit in our clinic. It's very important. So out of the CCSS, they also looked at these psychosocial late effects, which is good. And so these are just an example of some of the different reports that have come out of the CCSS and psychosocial late effects with childhood cancer survivors. My apologies, my computer is freezing again. There we go. This is my favorite slide. All of these pictures are used with permission, but a few of our survivors here at UI Health. The young lady on the top left picture, was diagnosed with bilateral retinoblastoma at 1 week of life. Luckily, it was caught in time that she did not lose an eye or to enucleation, but was treated with chemotherapy as a very small baby. We knew to screen her so early because her father also had bilateral retinoblastoma. So unfortunately, she inherited the mutation on that RB1 gene. She's standing next to her brother, who fortunately did not inherit that genetic mutation. So he did not develop retinoblastoma. The young man on the bottom left is standing next to Dr. Schmidt. If you know Dr. Schmidt, you know she is not an exceptionally tall person. He's 18 years old in this picture. So he was diagnosed with infant ALL, which carries a very poor prognosis. Luckily, he survived his disease, had a stem cell transplant, but had multiple late effects, obviously growth. Also, he had significant hearing loss as a young child, so that also affected his speech. And he had neurocognitive late effects. So had help in school, had IEPs, graduated from high school though, and is working at a hospital. He takes classes at Second City and wants to be a comedian. So hopefully he reaches his goals. The young man on the bottom right had osteosarcoma and unfortunately had a relapse to his vertebrae, but is about, I think, 5 or 6 years out from his therapy for the relapse. He is diligent about preventive health, does everything I ask of him, works out at the gym an hour a day, very healthy diet, but his ejection fraction is in the low 50s, which is within the normal range, but someone with that activity level definitely would expect higher. His ejection fraction was in the mid 70s before his therapy. So he definitely had late effects from his chemotherapy, also effects to his kidneys. So we're watching those two things closely. In the top right, this young lady was diagnosed with leukemia as a toddler. And she is a very bright, smart young lady, reading a couple of grade levels ahead. Hopefully she continues to do well. And the middle picture is we always have a Thanksgiving celebration for all of our patients. This was pre-COVID. Our last one, I believe, in 2019, us dancing with the Joffrey Ballet, who was provided entertainment. We did not have a Thanksgiving celebration, obviously, last year due to COVID. We'll see what this year brings. So just wanted to talk a little bit more about the long-term follow-up guidelines that we follow. They are evidence-based, based on the research, and the recommendations are updated every 5 years by a multidisciplinary committee. Currently, we're on the 5th version. So the recommendations from these guidelines are tailored to the survivor based on their prior treatment therapy. So before the patient comes in, I go to the medical records and gather all of the information about surgeries they had, radiation field and doses, chemotherapy, the type of chemotherapy and the doses, if they had stem cell transplant or other treatments. We take all of this information and put it into a computer program developed at Baylor University called Passport for Care. We were one of the first 11 beta testing sites, which I was very thankful for, because before this program, I had to go through 250 pages of guidelines by hand to see what we needed to do for our patients, but this computer program does it for me. So it generates a treatment summary that I can print out and give to the patient. And also it comes up with our follow-up recommendations or follow-up care plan. So we know what we need to do for each patient to make sure that they stay healthy. I provide copies of those as well to the patient, the primary care provider, and the oncologist, if they're an outside oncologist. Our first patient meeting, whenever we see patients for the first time, I sit down with patients and families and do an education session where we go over all of this information. Patients vary widely with what they know about their treatments, what their parents have told them about their treatments, if they were younger at the time. And then we go over the follow-up recommendations and ways to keep them healthy. So the guidelines recommend screening studies and the intervals where we need to do the screening studies. And we also provide, they provide health links to educate patients and providers about cancer survivorship. So this is an example of a cancer treatment summary. It's for a patient that had leukemia and relapse. So it's quite lengthy, not all of them are this detailed. But as you can see, it lists out the protocols. 60% of pediatric cancer patients are treated on a children's oncology group protocol. 80% at least follow a protocol. And so we always list those so the providers can get more information if they desire to. Surgeries, chemotherapy agents, this patient had a stem cell transplant. And then if we've already identified any late effects, we will list those out as well. This is just a small piece of the follow-up care plan that we provide to the patients and the PCPs. It's grouped by system, so we know what we need to do each year in our H&P, and also the screening studies that we need to do in labs. The newest part of Passport for Care is a portal for the patients, which is great. So I provide a binder at our first visit, but people move, things get lost. They forget to take a summary when they're going to see their eye doctor or their dentist. So they can now pull it up, their summaries up on their tablet or on their phone if they set up an account with Passport for Care. So Dr. Schmidt watched, read all this research and knew that her patients had late effects. And so we wanted to start a program here at UI Health for our patients so that they could have access to comprehensive long-term follow-up. So in 2009, we started the Childhood Cancer Survivorship Clinic here at UI Health. We wanted to establish it outside of oncology so that, we weren't having patients come in for their long-term follow-up. Oh, but there's a relapse, there's a septic patient that we need to take care of. We really wanted to focus on this for our survivors. Also, we wanted it outside of pediatrics because, as we talked about earlier, incidence of chronic health conditions goes up with time. We know at least until age 50. Many of these clinics are in pediatric institutions that can't see patients after the age of 21. So we wanted to see our patients throughout the lifespan. So we established it in medicine pediatrics so we can see all ages. To be eligible, you need a diagnosis of pediatric cancer. Again, no age limitations. we're med peds. I'm a family nurse practitioner, so we can see all ages. You have to be at least 2 years out from your cancer therapy, just because the first year or two, the team is really focusing on relapse if it happens. There's a lot of appointments. So we usually give survivors a couple of years and then bring them into Survivor Clinic. Some clinics require that you have cancer records, treatment records. Some of our patients are more than 25 years out, so the hospital may not have them. Some of our patients were treated in other countries and we don't have access to those records. So we have some patients, we try our best, but some patients don't have records. That's okay. This is our team. So Dr. Jabine is our attending physician. She is certified in internal medicine and also pediatrics. So she sees our new patients and then focuses on areas in the survivor care plan and does the follow-up referrals and testing. I am the nurse practitioner, so I gather all of the information before they come to clinic. I do a lengthy education session at the first session and then subsequent sessions as well, because it's a lot of information, it's overwhelming. And so just make sure that we follow up every year and then see our return patients and do care coordination. Zaida is our wonderful social worker who completes a psychosocial assessment every year and refers as appropriate. And then Dr. Schmidt provides oncology consultation if we have any cancer-related questions, because as we tell our patients, we are not oncologists. So we work very closely with her and then provides leadership. So most of our patients are referred from pediatric oncology here at UI Health, but we have referrals from other programs that may not have a survivorship program. And then, a few other different areas. Fortunately, at UI Health, we accept all of the Medicaid managed care plans. And so if someone is not able to be seen at their survivor clinic, if they have one of those plans, we can see them. We see patients yearly. Some of our more complex patients we may see more frequently. Then after they're seen by us for their yearly history and physical, we will send them for screening that's appropriate and then refer if appropriate. Unfortunately, we have identified many different late effects in many different systems here at UI Health. Unfortunately, especially in our RB1 population, some secondary malignancies and some late recurrences of the original cancer diagnosis. So our social worker, Zaida, what does that look like in our clinic? So she meets with each patient yearly to see if there are any barriers to care. So does an annual evaluation. And then if she identifies resources that they need, can seek out those resources for the patient. So she also can refer to, if they need to be referred to behavioral health. Many of our patients don't have access to dental care, so she works on that for them. Also, many of our patients, a big part of her job, which is great, which we need to do, any patient that had leukemia or radiation to the brain should have a thorough neuropsychological evaluation to see if they have any learning differences. So she is able to coordinate that. And then once we receive the report, if the neuropsychologist recommends any accommodations in school, she can work with the family and even the school, if the family is comfortable with that, to arrange for a 504 or an IEP plan. So some of the psychosocial barriers that our patients face, a big one is insurance. At 19 years old, kids aren't eligible for all kids anymore. At 26, if they're under their parents' insurance, they lose coverage. So Zaida, looks years before these things they reach this age and make sure that they are either applying for their own Medicaid or helps them find insurance coverage. Different work education disruptions, even as survivors, if they have multiple complex chronic health conditions, they may need time off work, they may need ADA accommodations at work. She helps them, as I say, she helps with adulting. So helping, kids transition from high school to whatever they're going to do after high school, whether it be Job Corps, trade school, college, employment, those things, addresses emotional needs, depression, anything else that she identifies during her assessment. And she really understands our family's unique needs. She also works in pediatric oncology. So often, she'll get to know the family there and then can also assess the family in Survivor Clinic, which is a nice bridge, as these patients don't know me, they don't know Dr. Javine, because we don't work in the pediatric oncology clinic. So she has some active grants, which is always helpful. Some cool projects going on with our younger kids where they get an electronic toothbrush, and they're provided with education from the dental school about good dental health. Chemotherapy affects the enamel on the teeth and the roots, especially in young children. So it's very important that they have good dental health. She has a program right now, Songs of Love, where the kids, give like their favorite things, things that they enjoy doing, and they have an original song written for them and performed, which I think is super cool. And she's also very active in the Pullman Supportive Oncology Collaborative for AYAs. We do a lot of education and training in our clinic, as I'm sure everyone does at UI Health. We have medical students, residents, fellows rotating through. Once in a while, we'll have a pediatric dental resident, which is great on both sides. They learn about cancer survivors. If we have patients who, we need a more thorough dental evaluation in clinic, they can provide that, which is wonderful. Nursing students, SIDA often has social work interns, which is great. And then undergraduate students, if they're interested in pediatric oncology or survivorship. We also, are happy to work with researchers if they would like to invite our patients to be part of their research projects. So I've had some researchers in different fields, community health or the dental school, pediatric oncology, recruit from our clinic if patients would like to participate. Also, since we are a COG member, we offer children's oncology group studies to our survivors. Have a few different ones that are enrolling right now that we've enrolled in, so that our survivors can be part of the research. Just a few final slides. I feel like you can't do a presentation these days without talking about COVID. So this is just showing a health link, a portion of the health link that I sent to a lot of my survivors during the past year and a half, talking about COVID. We've received a lot of questions about, am I more likely to experience complications if I get COVID? And also a lot of different questions about the vaccine. I had cancer. Should I get the COVID vaccine? Which is, the answer is always yes, right? So we've had a lot of conversations, a lot of anxiety this year, and I'm glad the vaccine is now available, at least over 12. So some of the challenges for our survivors the past year and a half, a lot of anxiety, especially with parents and survivors, about increased risk for complications. So I told all of my cancer survivors, you have had cancer, so definitely be very careful, especially if they have late effects to the heart or the lungs, or if they had treatments that can affect the heart and the lungs. As we discussed before, many of our patients have learning differences, neurocognitive late effects. And so remote learning was even more difficult for these patients, if they weren't able to focus much as a neurotypical child or if they have disabilities. Work stress, finances. Many of our patients are essential workers, and so they had increased risk of contracting COVID. Also, just because they may be living in crowded housing or may be living in multiple generation households. So we love to collaborate. I just thought I'd kind of wrap up by saying, call us if you have a pediatric cancer survivor who isn't being seen at another clinic. There's my phone number, email. You can always message me on Epic. Also, if you have a survivor, we do have Children's Oncology Group late effect studies open. Many studies go up to age 30, some even go up to age 50. So we are happy to chat with you and to see if your patient is eligible, so we could invite them to be part of that study. We're always open to collaborate with other research projects or invite patients to participate in other studies. We love to educate, so send people our way. And we have the Thanksgiving event, but we're always happy to collaborate with other events for cancer survivors. Thank you so much again for inviting us to present. And September is Childhood Cancer Awareness Month, so this was good timing. Thank you guys so much.
Thank you, Jessica. I know Dr. Javine is here as well. Dr. Javine, did you have any additional comments to add to Jessica's great presentation this morning?
Well, first I wanted to thank Jessica for doing the presentation. She is really the linchpin of the clinic. She's been there since the beginning. One of the reasons I feel comfortable being involved with the Childhood Survivor Clinic is because Jessica trained as a pediatric oncology nurse. We have Mary Lou Schmidt, who is an amazing resource and was really critical to getting this clinic off the ground. It required cooperation from two different departments, from the departments of internal medicine and the departments of pediatrics. And when you can get two department chairs to work together, that's a pretty amazing thing. So I'm really grateful for her work. She is really the linchpin of this clinic. The other thing I want to stress is the trust that the patients and parents put in us. They really get to know their pediatric oncologist well. They establish a relationship with them that they pretty much forget their primary care doctor at that point. And so to shift their trust over to us is a great gift. And Jessica does a very sensitive job of education. It's in order to start talking about all the potential late effects without scaring the heck out of everybody. You really walk a tightrope, and she does such a beautiful job of that. And I think the other critical thing is that because they're putting their trust in us, we have to, I take it very seriously in terms of reviewing their charts very carefully and really knowing their history before they hit the door. Because bringing up that history can be traumatic for parents, sometimes traumatic for patients. There is an element of PTSD. Not every survivor seems to come with it, but many of them have elements of PTSD going on in their lives. So the better we know them and understand what's going on, I think the safer they feel coming to us.
Great. Thank you, Dr. Javine. That's incredibly important, gaining the trust and building a relationship with your patients, and even more so in this pediatric population, because with pediatrics, you always have to deal with the parents. So that's a challenge probably to the healthcare for these individuals as well. Yeah, I have inherited a couple of your patients because I turned 26 in the adult cancer survivorship clinic. So I am aware of some of those insurance challenges, and it's interesting to think about the insurance challenges of these patients having a pre-existing condition from when they were young, and they must go through significant challenges. I think that's really amazing, the work that Zeta does, and in the clinic, and is something that makes me think about bringing a social worker to our adult survivorship clinic as well.
I think it's critical. Yeah.
Yeah. Right now we navigate a lot of that, but I think that is a really great opportunity, a really great avenue, because someone can really care for that comprehensive wellness of your patients. So I think that's wonderful. Have you guys been able to network with Tamara Hamlish at all with our Young and a Survivor? You guys may have some patients that overlap because she provides it leads the programming for the YAS grant. Tamara, do you want to talk about YAS for a moment? She's there.
Yes, I am. I'm happy to talk about it. But it's breast cancer only, and I didn't hear breast cancer mentioned in the presentation, so I don't know if you have patients who have a breast cancer diagnosis. I think
We do.
You do. Okay. So the program is generally for women, young women 18 and over, but we have resources for insurance, for community-based insurance, and community-based programs, as well as sort of highlights or guidelines for what kinds of clinical issues they face. We have resources for that, and then we're trying to build a network for them to plug into. So it's, I mean, for women that young, for girls that age with breast cancer, it's a little bit different than the population that we're focusing on, but we're happy to talk to you more about collaborating.
Okay. I do want to clarify a little bit that we have survivors who have second primary breast cancers. So these are people that at least one of them has an oncogene. I believe she's a P53. So we don't have any like young primary diagnosis, but we do have second primary breast cancer patients.
So for young women, for secondary, we definitely see that in our population, and we'd be happy to collaborate with you and talk about, how the intersection with our program, because those young women are older. If it's secondary, they're usually in their early 20s when that happens,
I think our group, we have in their 30s, right, Jess? The one I can remember. Yeah.
Yeah.
Jess, somebody had a question, and I couldn't remember the answer to that about Passport for Care, because I was talking a little bit about the logistics of bringing it on board and how that took about a year to vet between administration and the hospital legal. So I don't remember if we are, if that was gratis or if we are paying a fee to use that every year. And I don't know if you can answer that question. Maybe Mary Lou is the only one who would know the answer to that. But
oh, no, I can answer that. So that program is provided for free. So we do not pay for that program.
Passport.
we did have to have a legal agreement because of HIPAA issues and things like that. But we started as one of the beta testing sites, but now it's available to any children's oncology group institution for free, no charge.
And we stress to patients that it is, HIPAA protected. The other thing is that, sorry about that pager in the background. The other thing is that they cannot use our data for research. We cannot use other, centers' data for research. That would have to go back, and you'd have to reconsent patients to do that.
Yeah, no, it's clinical only. I mean, it would be a great platform for research, but no research is done out of that because of consent issues.
And the Passport, Passport to Care, that's childhood cancer specific, or is that for all cancers? Yeah, we need to develop a system like that for adults.
Yes, you do.
That's great. Yeah. So it is, it is from the guidelines, the Children's Oncology Group guidelines. So that does just cover pediatric malignancies. Although, obviously a lot of the chemotherapy and radiation that we use, is used in adult world. So the things that it pulls out, if a patient has cyclophosphamide, right? If your patient had cyclophosphamide, you could do the same thing. So there would be some crossover there.
I hope someone is working on that for adults right now to get all the guidelines, because the guidelines are expansive. So I get it, what you mean about huge documents and many things to go through.
When they offered us to be a beta testing site, I'm like, yes, please. I'm tired of going through 250 pages for every
godsend. It really was. Yeah.
Betty,
I want to I don't know if there are any residents or fellows out there. I did want to say in terms of how I was brought into this by Mary Lou, who knows me as a med-peds practitioner. As a primary care doctor, I would not have touched this initiative if there wasn't very strict guidelines through COG for how to handle these patients. My training is not oncologic. Jessica has training in peds oncology nursing. I have Dr. Schmidt. We have those resources, but the kind of people who come into survivorship care, it's anything from med-peds graduates to people who have done adult or pediatric oncology fellowships. So there's a spectrum of people who do this work. So I just wanted to point that out if there are any residents or fellows out there listening.
We have a couple of questions from the chat. I'm trying to get these all together here. Betty Rogenkamp is wondering, how are the copies of the passport for care shared with patient or family and PCP, electronically, paper, or through EMR? And does the patient portal through passport contain a complete survivorship care plan?
Yeah, so pre-Epic days, I would, get the primary care provider's information from the patient if they have one. And then, with Dr. Devine's note, I would fax over the cancer treatment summary and the follow-up care plan. I do share written copies of the treatment summary and the care plan with families at the first visit. I put together a binder with multiple copies of those and go through it with the patient. Also, written copies of health links. They can access their care plan through the portal, so that whenever I meet with them, I give them an access code so they can go to that website that I showed and set up their own account. So they do have access to their care plan.
Cool. And Betty also gave us a checkout Oncolife. So, so we have to check that out for adult cancer survivor management. I see multiple people from our partner Wellness House here. Are these services that our pediatric cancer survivors are utilizing as well and told about?
Yeah, we haven't really partnered with Wellness House too much. So yeah, I need to take a closer look at that, definitely.
Yeah, we should set up a meeting to talk to Jill or
I was thinking the same. It'd be really wonderful to set up a meeting and talk some more.
Yeah, let's do it.
yeah, we love collaborating with Wellness House, bringing those services, try to talk to all of our adult cancer survivors, and the pediatric cancer survivor group would be great to participate in all of this, and just trying to get that word out for that more. Does anyone else have any other questions? I don't know if there's anything I missed in the chat. I was trying to look through all of them. I think that sums it up, and we're about at 10 o'clock. Again, thank you so much, Jessica.
Thank you.
Dr. Gantry, did you have something you wanted to say?
No, I just wanted to say thank you. I'm sorry I had to come to this late, but so great to learn about this incredible program that you all have developed. And I think that, you know, in adult survivorship, we can learn a lot, right? We don't want to all reinvent wheels. I think the addition of a social worker and like Debbie that you mentioned, we really should consider bringing on board in our program too. And I think, you know, the connections that we're making to Wellness House and to other resources that are in this group are really important and part of the goal of having these educational sessions together. So, you know, we aren't doing just this in isolation. So thank you very much. I'm looking forward to getting to know all of you. I'm doing that slowly as I've just come on board in March, but really impressed with all of the work that's being done. So thanks so much.
Yeah, thank you, everyone. Have a great rest of your week and weekend. And next month, we'll send out a reminder about that. Thanks, everyone. Bye.